Hello, my name is Pam Markle. I am the Field Marketing Manager for Public Sector Healthcare of Polycom, and I have the pleasure today to introduce our topic and our speakers today. We're going to be talking about the role of telehealth in pediatric oncology and also some of the challenges of treating this class of patients with telemedicine applications. I'd like to first introduce Dr. Kuo. He is the Pediatric Residency Director at St. Joseph Children's Hospital in Paterson, New Jersey, and he also is an Assistant Clinical Professor of Pediatric Oncology at Columbia University in New York City, New York. And then with Dr. Kuo will be Ron Emerson. Ron Emerson is our Global Director of Healthcare here at Polycom. Ron is a former member of the Board of Directors for the American Telemedicine Association and also chaired the industry group. He has 17 years experience in the healthcare industry, and he will be part of the Q&A process or moderating conversation with Dr. Kuo. Ron, I'm going to turn this over to you.
Okay, thank you very much, and we'd like to thank you, Dr. Kuo, for taking time out of your busy schedule to be with us today. So, what I'd like to talk about first is I know we all realize that we're seeing many challenges in healthcare. We're seeing healthcare reform. We have a shortage of healthcare specialists such as yourself, and especially specialists such as yourself across a variety of areas. What I'd like to touch on first is, can you just give us some examples of some of the challenges and pain points that you see in your day-to-day practice around being a pediatrician, a pediatric oncologist, and a subspecialist, and as far as gathering medical knowledge and distributing medical knowledge to those who don't have it, and what the barriers are and some recommendations and technologies that you're seeing being used in that space?
Only 1 in 300 children have a cancer during the first 18 years of life. By comparison, about 1 in 3 adults will have a cancer at some point in their lives. Fortunately, children do not have cancer at such high frequencies as adults do. That being said, the prevalence of pediatric oncologists in any population is also much lower. Therefore, in certain areas of the country where there's not as high access to pediatric subspecialists, one can be at quite a distance from a pediatric oncologist if one needs a referral. So that's one aspect, from the referral pattern from the general pediatrician to a pediatric specialist such as a pediatric oncologist.
As a subspecialist, how well do you think, when you're educating from a distance and the experiences that you've had, how independently and what level do you feel you're able to allow clinicians to work more independently and provide higher levels of clinical care based on just the educational component that you provide from a distance?
It's very difficult because people want you to be able to review the images, review the peripheral blood smears, and without being able to actually set your eyes on these critical pieces of information, it's hard to be able to give a general pediatrician out in a more remote area a definitive answer which they would feel comfortable telling their patient without having you physically seeing the patient yourself.
Can you just go over some experiences that you've had as far as providing education and also receiving education on specific clinical conditions for pediatric oncology?
Pediatricians often want to have a patient referred for an evaluation to see whether or not they have cancer or not. Electronic medical record systems are developing such that they are starting to learn how to talk to each other. In this current state, sometimes physicians are able to use their electronic medical records to send you information. However, haven't gotten to the point where they can send you actual images. Even though kind of certified electronic health record technologies are supposed to be able to transmit images or store images and send them to another physician, real utilization and meaningful use of these kind of resources has really not happened yet. So we have to rely on other methods to get the information and the images and the studies before we're able to actually review them and be able to give feedback to providers.
So it's interesting your point, because when we think of telemedicine, it's those key components. It's about that live interaction between a clinician such as yourself and the patient, or discussing a case with another physician or a group of physicians. But it just shows how critical having all of the real-time patient data, so you can provide appropriate clinical decision-making is.
People often get imaging studies locally. They will have some kind of suspicion for a mass, and they will get an imaging study done locally. The imaging study done locally will not necessarily be easily transmittable to us in a form that is with adequate detail so that you could make a good medical decision on it, and then sometimes that requires that you essentially redo the study because your radiologist in your center may not feel comfortable with the films or the CD version which has been brought over.
Oh, exactly. Now to that point, we're talking about having access to the clinical data. As a pediatric oncologist and a subspecialist who's in an area where you're located, we do have as we discussed previously, a fair number of pediatric oncologists. As we look at sort of the maldistribution of specialist providers such as yourself, what role in your field specifically do you see applications such as telemedicine, that live interaction where you as a subspecialist are in one location and you're providing a live consultation with a child and the local clinician in their own state, trying to provide the expertise to overcome the geographical distances that we face? And how realistic is that, and what acceptance level do you feel, based on your experience with as an expert in your field and with children, the acceptance level from children and families, and that you would expect from other clinicians?
Our field is a very kind of hands-on field. If you are not able to see the patient, it's hard to make a good clinical judgment on them. Having said that, there's definitely a lot to be gained by being able to see the person in live action in a video screen via high-def telemedicine, which you cannot get just by either talking to them on the phone or seeing pictures or having kind of labs faxed over to you. So in a scenario where it is of extreme difficulty for a patient to kind of be seen at a tertiary care referral center, I think one has to seriously consider whether telemedicine from an office where a clinician is able to work with the patient to provide the subspecialist a reliable physical exam, and then allow the subspecialists such as myself to be able to talk face-to-face via the teleconferencing system to the patient is invaluable. And I think that would be able to be well accepted in areas where it is well known that it's difficult to access the care.
From your personal and professional experience, what components of the physical examination, as you think of having that, if you have the real-time data, you have the CAT scans, the MRIs, the blood work, whatever you need as far as data goes, what pieces of the actual physical examination would you find most helpful, and what other components of it do you think would be challenging providing that care from a distance?
I think from a consultation point of view, one of the hardest things to tell is whether or not someone's lymphadenopathy is enlarged or malignantly enlarged or enlarged in a way that is truly concerning. We see many referrals here at the Pediatric Hematology Oncology Center, and some of the people who are referred for lymphadenopathy have genuinely concerning lymphadenopathy. Some have very small lymphadenopathy. However, when I see a patient who is going to be seen for lymphadenopathy, often enough I can't tell whether it's going to be a significant finding or a non-significant finding. But if one were able to have a clinician there in person guiding the physical exam with a patient in their office, I think that one could avoid a lot of unnecessary referrals by merely being able to point out to a clinician locally, say, all right, show me the lymph node that you're concerned about. Measure it. How big is it? And then to be able to say, when you're feeling it, is it hard? Do you feel there's divisions between multiple different lymph nodes, or is it all one large lymph node? And that kind of aspect, I think one could be able to elicit with a experienced clinician on the other side. So it wouldn't be the same thing as asking someone in their home to tell you how they're feeling, because that wouldn't give you a physical examination that would be reliable. However, a reliable clinician would be able to essentially do a physical examination, which is well within the scope of any general physician's scope of practice, and then you, being the clinician who is observing this, would essentially be able to add your subspecialty expertise to this.
No, that's great, and you really bring up a valid point too, Doctor. I mean, what we see, when we look at a lot of clinical applications that are being provided by telemedicine is part of it is how can we utilize distant technologies where we can sort of integrate and begin to get people into the system, right, where they have access and we can actually feed them into the system, where in other ways where they actually wouldn't even have access to a specialist such as yourself. And then the other piece of that is, once they're engaged and they're interacting with you, the specialist, then how do we provide sort of the continuum of care and that continuity where we defy distance, right, where, no doctor is too far away, where we allowed you to be able to connect to them and monitor that patient ongoing. So that's very, that's very in sync with some of the specialties that we're seeing today. And I think the interesting part and why it's wonderful to have this discussion with you is that in pediatrics, and especially, some subspecialties such as pediatric oncology, which is more of a, which of course is all areas can be very delicate, but of course this is an area that, reactions and sensitivities are very, very important. Now, sort of changing gears a little bit, we've talked about distance education and the spread of medical knowledge from folks like you, the folks who have it, to those who don't, or you connecting to another clinician who maybe is a subspecialist or a specialist in a certain clinical area of pediatric oncology. The next piece is that I want to talk about in an area is really the whole multidisciplinary team environment and what you see in your current practice when you review a case, let's say at St. Joseph's, and how do you see this sort of approach being utilized from a distance, where using distant technologies such as video and other technologies with real-time data, where we could have the GP in the rural area involved in the multidisciplinary team meeting, where we could have the family members in the rural area where the child is going to go back to after discharge from the hospital. How do you see that working out, and what are some of the challenges that you face now that you think we might be able to leverage technology to help overcome as things move forward?
Sometimes I think that in this kind of realm, people haven't even realized that one could do it this way. Thinking back in my training, actually, in my fellowship, I was a pediatric hematology oncology fellow in California, and some of the patients would come from 3 miles away for their visits. And then on the in-between weeks when we wanted to know what their lab results were like, we would basically have them either go to a local lab and have labs drawn and the lab results sent back, or a visiting nurse would go out to their house and draw labs. But we never actually examined them. After moving back to the East Coast, where most of the patients are much closer, we see the patients more frequently, and that gives you a better level of comfort with what's going on with the patient, and it gives the patients reassurance that you're not just looking at labs and thinking they're okay when the person is feeling sick at home. Rather, you're seeing them like much more frequently, like every 2 weeks. And, back in fellowship, we just assumed that this was the way it was. You would see the patients once a month, and they would just get labs sent to you, and you would just call them back and tell them their labs were okay. And you would have a little conversation with the parents on the phone, but you would actually never see the patient if they were, living at such distance, whereas the patients who live nearby you saw all the time. So it created a kind of inequality of care just based on geographic randomization, basically. That's, with, teleconferencing technology, one could erase that difference.
Well, it's interesting, and the reason I bring that up is, Polycom. I mean, we are doing, a lot of work in this area. Specifically, one area that we've seen a lot of growth in, as far as multidisciplinary team meetings, is in the UK. And we had a brief conversation about this before, Doctor. There's some mandates that a multidisciplinary team meeting has to occur on a regular basis, and they're using distant technologies such as video, the ability to be able to share packs, real-time patient data, electronic health records, and connect across the continuum. So if the patient lives 2 miles out of the bigger city, they can connect to the GP and have them involved in the actual multidisciplinary team meeting. They can have the family members who are 2 hours out away from where the oncologist is. They can have the radiation oncologist who might be in a different location, and we can bring all of these different experts together to make the best overall decision of course, what's best for the patient and the best support structure. And that kind of leads us to the next point, which is really interesting in an area is, we're seeing this large shift, as you know, we're seeing this shift in a lot of areas of healthcare as we move more towards quality-based care. We're moving away from fee-for-service care. And as far as quality-based care, we need to move outside, as you said a little bit earlier, Doctor, that we need to move outside of, not just seeing a person once a month, but how do we have not just the clinician, but how do we have the care team provide increased contact with patients regardless of where they're located. And it's interesting if you look at where are we usually located, especially children. We're either at school or we're in the home, right? That's where most children are. And if they're ill, we need to be able to reach into the home. So we see a lot of healthcare organizations that are very, very interested in how we can focus on prevention and how we can focus on wellness and how we can focus on changing people's behavior. Now, in your case, of course, that would be maybe a child who's already been diagnosed with cancer, and we have educators who are checking in and nurses who are educating them on how to keep a sterile environment to ensure that everything's going okay if they're immunocompromised or whatever that might be. So I'd just like to get your thoughts on sort of the whole wellness and prevention piece. I think it's very clear when we look at like congestive heart failure and heart attacks and different things that we can change people's behavior. How do you see it?
All right. Well, there was something that one point you mentioned I think actually does kind of is very salient, is that in general, healthcare organization is moving towards the kind of accountable care organization structure, pay for performance, and essentially integrated care networks. And the kind of reimbursement structure is moving hopefully from a kind of fee-for-service structure where the person who happens to have more visits gets reimbursed more. The person who has less visits gets draws less of a reimbursement rate. At the end of the day, what everyone really cares about is that the patient gets good care. However, if good care requires that you physically kind of like see the person, then that's going to either require a lot of driving on the patient's part and is going to be kind of more costly because it takes up much more kind of facility time. If I do find that integrated systems, if you look at, say, Kaiser or something like that, people in integrated systems use less subspecialty care and they use less visits. However, they use other means, like they use their general practitioners or nurses to essentially maintain the continuity of care without essentially having the subspecialist continuously see the patient in person. Exactly. Whereas the fee-for-service system encourages a preponderance of visits. So if one were to be in a completely integrated care system with a essentially capitated reimbursement schedule, one would think that use of video teleconferencing would be able to cut down on a lot of unnecessary visits that could be substituted for by a video contact with the patient, which would be more convenient for the patient and the family, not bring them into the kind of like medical setting where they can be exposed to germs and other kind of hazards, and also potentially be much more time efficient for the clinician also, who would be able to, from the office, meet with multiple people without having to essentially deal with the workflow issues that come from being in the office or having office visits.
Exactly. No, those are all very, very good points. And what do you think, doctor, from your perspective? And you said, at the end of the day, we're all in medicine, and especially folks like you who, go the long haul and are really doing things for a lot of good people. We want to do the best thing for patients, but of course, from an administrative perspective, we have administrators who, of course, we want to do good things, but at the end of the day, to keep the lights on and keep things moving, they are looking at the business case of the different decisions that are made that do provide better clinical outcomes, but also can have a positive effect, or at least an equal effect, or a balanced effect on the bottom line, right? What do you think Go ahead.
I think there needs to be better distribution of information about the reimbursements for video teleconferenced visits, because if physicians and administrators realize that one could be reimbursed for those types of visits, then that would encourage more outreach using these kind of technologies, because up until now it's considered largely a freebie when you do a video conference, or if I call up a patient and talk to a patient for an hour on the phone, that's a freebie, which I'm happy to do because I want the patient to get cared for, and if the patient doesn't want to come in because it's inconvenient, they have a lot of other things on their agenda, or it's physically difficult, or they live very far, or both parents have to work and can't bring the child in, it's understandable. But it creates a really unusual dichotomy, or it creates a distance or a kind of disruption between the work you're doing and the reimbursement that you're getting for it.
Exactly. And and what's interesting about that, Dr. Kuo, I think that's really interesting. Of course, we keep a very close eye on this, and you bring up a very valid point. One thing is, there actually is reimbursement on some levels. Of course, you're located in a state where, so if it's Medicare, or if it's if someone's on disability, Medicare disability, a live interaction between a clinician such as yourself as a patient is a reimbursable episode, but the patient has to be physically located in a non-metropolitan statistical area, or they have to be in a HPSA, health provider shortage area, and they have to physically be located in a physician's office, a clinic, critical care access hospital, skilled nursing facility. So the one I did not mention is the home, right? So some of what we're talking about, the home piece really doesn't apply. And of course, then Medicaid, has its own set of rules. Each state dictates. And if you look at Medicaid right now, 19 states actually have legislative mandates that all payers have to reimburse for telemedicine, but there is some criteria, and then the payers are the payers. So there's only 6 states that do not reimburse for Medicaid reimbursement. But to your point, though, and I think the interesting point that you brought up is the next step of this whole process is as we move more away, and you articulated it very nicely, away from the fee-for-service model, more to the population health model and quality of care model, that when we receive sort of capitated global rates, that's going to be the incentive for the clinicians to utilize technology to reach into the, or other physicians or other clinicians to reach and use this technology to reach into the home and provide sort of that higher level of interaction and more frequent and increased frequency of care. So we're starting to see that shift already, which is very, very interesting. So I think that'll help sort of close that gap on those blurred lines.
So I think so that's kind of like that's the kind of distant future of kind of integrated care networks and actual pay for performance and accountable care organizations and that. I think before we get to that point, we do have a situation where one has a related kind of set of issues, which is that even within the field of pediatric oncology, there are various levels of subspecialization. And as a pediatric oncologist, one knows where one would seek additional consultation from. Usually that extra kind of like level of consultation is from a nationwide expert or a regional expert in the field. At that point, it can be difficult for a patient who is already seeking oncologic care to go further afield in order to see a next level of subspecialty consultation. And honestly, because of insurance issues, especially if the patient is in a closed HMO or in a state Medicaid system where one has very limited opportunities to see doctors outside either the state or the network, one then finds oneself in a situation that it's very difficult to obtain that extra kind of consultation. So, for example, there is a physician in southern Illinois who is an expert on opsoclonus myoclonus syndrome. Over here in New Jersey, we have some patients who have opsoclonus myoclonus syndrome, and we would like to get the input of this particular doctor in southern Illinois. Currently, in order to do that, one has to petition their HMO here or the Medicaid office here in order to get an authorization for the patient to go all the way out to southern Illinois to see this person. And then they only see that person once. The person writes up some recommendations and sends the patient back and never sees them again. If we were able to arrange a teleconference with them, they could see the opsoclonus myoclonus, which is the actual, it's a movement disorder essentially. So the clinician over there would be able to see the movements which we're trying to talk about, give advice, and then we would be able to act on it, and then subsequently they would be able to see the follow-up afterwards without having to try to have the patient go through the whole authorization process again and go all the way out to southern Illinois, which is a major inconvenience.
No, that's all. That all makes sense, and I think that as things are changing, as demands. A few things that we're seeing in the industry, I think in general, and to your point, is more and more we're seeing clinicians and specialists and subspecialists that are basically they're employed by hospitals themselves, right? So the hospital is sort of changing their mission and different modalities, to meet some of the reform that we see. So I think that's going to help alleviate some of the reimbursement concerns and incentive concerns, of course, and then, what you articulated, as I said, very, very nicely, the whole change away from just fee-for-service, where we have the entire care team working to provide different populations, and including, pediatrics and children with cancer. We're going to see the same effect. So,
in general, these other consulting doctors I find to be extremely open to talking about the patients, and these are colleagues who through national conventions. They in general are not that interested in the extra reimbursement for like a one-time consultation. They would be happy to see the patient via teleconference with you for kind of like 15 minutes and essentially not have to do anything further without worrying about the reimbursement, because that's kind of that's not why they went into medicine either. They went into medicine because they want to help patients. They don't really concern themselves that much with the value of a one consultation visit. But without the ability to see the patient, they won't be able to give you any kind of useful advice. So I find that if one is able to kind of coordinate this kind of live conference with imaging and to see the patient and to actually get a feel for what the patient's condition is, they're in general quite happy to do so. And I think that that's actually a neat evolution in this technology.
Well, and I think what'll be interesting is you just brought up a very a situation that we've seen many times, and I've been doing telehealth for about 12 years and used to run a large telehealth network. And, what we sort of had in the beginning in a lot of these practices was we would just have a few doctors that like telehealth and were doing some outreach. And then, organizations that have really developed and embraced telehealth and have really aligned telehealth with the strategic goals of how they choose to take care of a given population, they've aligned these different technologies in place, and it's sort of become the fabric of how they work, and it's part of their DNA as an organization. So it'll be interesting as we have some of these, super subspecialists who look at a specific and specialize in a specific area. As these requests become more and more, and as the technology continues to get better and easier, and data transfer becomes easier, we really see more and more of an opportunity to leverage these resources where it's not so complicated and it's not just a one-off, but it really becomes sort of part of the way that they can provide assistance to a lot of colleagues and a lot of people and help a lot of these children with specific clinical situations, and everything's not in silos, right? So that's the dream here. So do you have any parting words, Doctor?
No, thank you very much for your time, and I hope that there's continued evolution in this field because I think there's great potential.
We really appreciate your time, Doctor, and thank you for all your insight and your knowledge, and thank you. So we'll look forward to working with you in the future. Thank you.
Thank you very much.
Thank you for joining us on this webinar. If you have any questions about this webinar content or for more information on how telehealth technology can be used in your practice, please feel free to contact us at my email address on the slide, pam.markle@polycom.com. Thank you so much for your time. Bye.